So let's study about orthopedic disorders. So initially, let us see how are the joints in the body. These are of different types: fibrous, cartilaginous. What you see the difference in this? In between the two bones, this is one bone, this is another bone. It is connected to each other by the fibrous tissue. While cartilage joint, you get a hyaline cartilage. And if both the things you are getting, there is fibrocartilage, midline symphysis pubic. So the type of fibrous joint is skull sutures. You get to some of the features like skull sutures, then interosseous membrane, inferior tibiofibular. Tibia and fibula, they are connected, so that is syndesmosis there. These are all fibrous joints. 11th to 12th costal transverse ligaments. So cartilaginous joints, it can be primary or secondary. So when you see there is primary, this is secondary. Sternochondral joint is hyaline cartilage, and midline pubic symphysis is fibrocartilage. Atypical synovial joints, and there are, if you see among the synovial joints, there is atypical, typical. So what is there in typical? These are the articular surfaces. You can see these are articular surfaces which is covered by hyaline cartilage. While atypical, you get fibrocartilage. These are the fibrous tissue, fibrocartilage, hyaline tissue, hyaline cartilage. And these are atypical synovial joint, which is by the fibrous. Examples are temporomandibular joint, sternoclavicular, acromioclavicular, 2 to 7 sternochondral joints. They are atypical synovial joint because they have got fibrocartilage, and typical synovial joint has a hyaline cartilage surface and the joint is there is joint fluid. What are the movements? This is a plain joint where they get a gliding movement. Now these are the types. Hinge joint, interphalangeal, there is only flexion and extension, two movements. Modified hinge joint, there is little bit rotation in the flex knee. So there is flexion, extension and rotation. Condylite joint, metacarpophalangeal joint, there is flexion, adduction, and even on this side lateral movement is also there. Flexion and little bit extension and circumduction. It can move in the round. That is metacarpophalangeal joint. You can rotate a finger. And first carpometacarpal is saddle condylite. The difference is condylite and here is saddle. Flexion, extension, adduction, abduction, circumduction, and there is opposition also. Means it can little bit move out of the slide it and it can oppose. This is the end of the annular joint. In between there is, this is radius head and this is annular, pronation, supination, atlantoaxial, pronation, supination. This is a common ball and socket type of joint. So bone physiology, if you see, there are different types of cells in the bone. These are osteoblast, osteocytes and osteoclast. Blast, they produce the bone. Clast, they just try to remove the calcium from this, dividing. Active, they, and osteocytes are the cells on the bone matrix. So parathormone, vitamin D, and these all, they have got the receptors. So calcium is removed from the bone by the parathormone, and vitamin D, it deposits, calcitonin deposits. Calcium is a critical role in cardiac, muscle and nerve function. Normal dietary calcium is 1500 to 1300. During pregnancy, it increase calcium level directly regulated by parathormone and vitamin D. These are the two important. Phosphates are important for as a bone mineral compound. So parathormone, whenever there is decreased serum calcium, that stimulates the parathormone and that cause stimulation of the bone to release calcium calcium is increased. Decrease calcium, parathyroid stimulation, that causes bone to increase calcium. Bone resorption is there. Resorption of the bone. Vitamin D from the skin 125. This causes hydroxylation of precursor of the vitamin D 125 hydroxy cholecalciferol. So that is the finally it is formed in the skin, then in liver, and again from the kidney. This is formed. Calcitonin, that causes release of when the calcium is elevated. Calcitonin is released when calcium is elevated. It causes calcium to deposit, inhibits osteoclast, and increases urinary excretion. Estrogen also causes important for calcium metabolism. Hypercalcemia, this can be primary hyperparathyroidism. Symptoms like nausea, bones, confusion, coma whenever there is increased calcium. Typically parathyroid adenoma, overproduction of parathormone, brown tumors, increased serum calcium. Secondary, it is because of malignancies of the lungs that causes increased immune syndromes. Decrease in calcium level, hypocalcemia, it's because there will be hyperreflexia, Chotex, Trozius sign, papilloedema, decreased parathormone production result in decrease in serum calcium. Post-thyroidectomy, whenever there is damage to parathyroid gland or parathyroid accidentally removed, that may cause hypocalcemia. So what are the metabolic disorders? Osteoporosis. This is the bone density, bone mass, quantitative problem. Most common in elderly patient. Type 1 is most common. This is type 1. Most common affects cancellous bones, femoral neck and all that. Type 2 is age related. Both cancellous and cortical bones are affected. Scurvy is caused by deficiency of vitamin. There is calcium deposition. There is problem with the deficiency. Osteoporosis is the marble bone. Osteoclast dysfunction is there in osteoporosis. Petrosis. There is hard marble bone but easily breakable. In Paget's disease, simultaneous osteoblast and osteoclast activity, there is dense but brittle bones again. So there is rheumatoid arthritis versus osteoarthritis. There is a difference. RA is and osteoarthritis. This is inflammatory, this is mechanical. So this is worse on walking with relieved by exercise, rest, morning stiffness only for 30 minutes. This is less than 30 minutes. NSAIDs relieves it. Simple, relieved by simple. Autoimmune, this is an autoimmune disease, rheumatoid arthritis. This has got previous history of injury. Osteoarthritis. Signs are joint, there is warm, joints are cool, no erythema. Local, there is no inflammation. ESR is raised here, normal ESR, CFP. Autoantibodies are formed. Here there is no autoantibodies. Changes in the radiograph, there is joint space narrowing. This is important. Joint space narrowing is there, and the important is Botany deformity and swan neck deformity. These are the two specific Botany. This is what you see is proximal interphalangeal. This is one phalanx, this is another, this is one. Three phalanxes are there. This is proximal. This is metacarpophalangeal joint. So there is hyperextension. This metacarpophalangeal joint is extended. This is behind, it has gone behind. And flexion, proximal, and this is distal interphalangeal. DIP is extended, this is flex, and this is extended. This is extended, this is flex, this is extended. So extension, flexion, extension. DIP, interphalangeal, metaphalangeal, extension, flexion, extension, EFE. While swan neck deformity, there is DIP flexion. It is a terminal phalanx. This is flexed, and middle phalanx is extended. So this is swan neck. This is the difference. Terminal phalanx. His terminal phalanx is extended, terminal phalanx is flexed. See the difference. This is flexion, this is extension, terminal phalanx. And osteoarthritis, you get two different types of nodes, Heberden, Borchardt nodes. H is distal. H is distal and B is proximal. Means this is proximal interphalangeal joint. This is distal DIP. DIP. This is P, proximal interphalangeal. PIP is B. B is PIP. H is DIP. H is dip. Haberden is distal. So rheumatoid arthritis, you get chronic inflammatory status, symmetrical polyarthropathy is there, small joints are involved, erosion, subluxation is there. Management is atlantoaxial subluxation can be there. Celastic implants. Osteoarthritis, you get a degenerative disease caused by wear and tear because of trauma on the surfaces. This is senile and secondary osteoarthritis. Pain relief, analgesics has to be given, weight loss should be advised. Disturbance is there, then you go for arthroplasties, replacement arthroplasty, osteotomy, excision arthroplasty. You get arthroscopic examination. Loose bodies. Now what is this loose bodies? Knee. Most of the time in the knee there is some osteochondritis which is desiccated and torn menisci. The form and swelling they cause locking, difficulty in locking of the knee. So you can see these are the loose bodies. Loose body in between, that is loose body. Osteochondritis dissecans. This is a necrosis. Dissecans, drops in the cavity. Medial femoral condyle. You can see this is the osteodesicans. This is medial femoral condyles. These are separated and necrosis there. MRI high signal T2 images. Now what is Charcot joint? This question is there on this. There is pain and proprioception is lost because of neuropathy, and then it may be common in diabetes, stapes dorsalis, syringomyelia. So these are the common conditions, even leprosy. Now it's not common nowadays. Ankle foot arthrosis. Acute hemorrhosis is because of the bleeding disorders. There is some bleeding in the joint and chronic and may cause muscle spasm, bruisings are there, possibly a factor 8 replacement has to be there. So osteomalacia and rickets. Rickets is in growing stage, osteomalacia in the adults, vitamin D deficiency. You can see rickets, there is bowing of the legs, wide bones. The legs are bowing. You can see legs are bowing. One and another part, very important thing is that there is, I think they are not shown, bone fractures are there, bowing legs, hypocalcemia, myopathy, wide bones, odd shaped legs, wide ankles, cupped. This is cupping, metaphysis. This is cupping of the metaphysis. Looser zones, pseudo fractures, calcium and vitamin D deficiency. So what is gout and pseudogout? There are two types of crystals you see in the gout: monosodium urate crystals and calcium pyrophosphate. Calcium pyro, CP is pseudo, sodium mono is gout, actual gout. This can be seen ankle, wrist, pseudogoids, larger joints, gout attacks, abrupt painful, maximum intensity 8 to 12 hours, polyarticular. The difference in the gout and pseudogout is gout smaller joints, pseudo is larger joints. Uracemia, hyperuric acid is there, and it is hypercalcemia, calcium pyrophosphate and uric acid. Negative birefringent test, and this is positive birefringent in pseudogout. Osteopetrosis, or also called as marble bone. Marble, it is breakable but hard, dense and prone to breakage. You can see this picture. Normally the osteoclasts are breaking down the bone and osteoblasts are forming the new bone. But there is difficult problematic osteoclastic activity. So bone is not properly broken. It may be abnormal, osteoclast cannot break down the bone properly, but osteoblasts are functioning its own. So they just try to deposit the bone more and more. It is just like there are two types of autosomal dominant AS and autosomal recessive. Autosomal recessive is ARO, infancy, this more dense and more loss of hearing, paralysis of veins. So this is more complicated. And autosomal dominant, side to side curvature of the spines. So excessive bone deposition is there. So it is maybe sometimes you get X-linked and cause lymphedema and all that. Now, what is this Paget's disease? Affected bony skeleton appears more often in the spine, pelvis, long bones of the limbs. So there is remolding. Normally there is remolding of the bone. What happens? Osteoclast dies to absorb the bone, and osteoblasts make the new bones. These two activities are going on: osteoclast absorption, osteoblast deposition. But when osteoclast is not functioning properly, in Paget's osteoclast are more active than osteoblasts. So they are trying to divide. But to counter the action of clast, the blast is working overreacting. It is just like a person is forming the brick wall. The bricks are laid down like this in a proper manner, one after the other. So the wall is constructed in a very systematic manner and you are fixing it. So when normal function is going on, but some person is doing in a very hurry, they are just trying to put one brick like this, another brick like this, then brick. So if you are doing in hurry, so there will be very odd, some projections will be there. So bone is deposited in very odd manner, and this leads to this type of kyphosis, bending, bossing, excessive bone reabsorption, and haphazard bone growth. Haphazard, just like making haphazard wall, usually asymptomatic, weak mesophine bones, fractures, nerve compression. So this is lytic phase, then mixed phase, sclerotic phase. So what happens in this? Irregular mosaic bones, bone pains are most common, fractures, deformities of the bones can be seen. Paget's is active in several bone overactive class, fatigue, weakness, loss of appetite. Paget's may turn into sarcoma. The management is non surgical, NACIDs has to be given, then SS2 devices are given. There are several types of bisphosphonates. What you give bisphosphonate medication is one of the bisphosphonate treatment of choice. Drug blocks the osteoblast. There are several types of bisphosphonates which are orally as well as intravenously. Doctor will ask you the types of treatment with following alkaline form. Surgical treatment is bony fractures, malignancies, arthritis. In that you need surgery. This may be internal fixation, osteotomy, and total joint replacements. This is important. Osteoporosis. This is risk factor family history. Females are very common because of estrogen, menopausal, deficient diet in vitamin D, calcium, sedentary lifestyle, smoking, premature menopause, low body weight, Asians. So what happens? Endocrine, Cushing's, steroids, hypothyroidism, hypogonadism, all they may lead to osteoporosis. Multiple myeloma, GIT disturbances, rheumatoid arthritis. Secondary prevention also nice guidelines. Those who are confirmed to have osteoporosis at score 2. In women above 75 years, DEXA scan may not be required because they are already menopausal, and vitamin D and calcium supplementation has to be given. So what are these? Alendronate is the first line. Around 25% of patients cannot tolerate it, usually due to gastrointestinal problems, and patient may be offered with risodronate or etodronate. So management of osteoporosis. It is secondary prevention also by giving vitamin D and calcium supplementation. Alendronate is the first line of treatment. 25% of the patient cannot tolerate alendronate. So bisphosphonates, alendronate, and risodronates all are licensed prevention and treatment of postmenopausal, and all three have shown to reduce risk of both vertebral and non-vertebral fractures. Vitamin D supplementation, poor evidence-based suggests raloxifene, selective estrogen receptor modulator, has been shown to prevent bone loss due to reduced risk of. It has been to may worsen menopausal symptoms, increased risk of thromboembolic phenomena. So strontium is also dual action bone agent, may increase. Strong evidence base may be second line of treatment. Osteomyelitis is an infection, immunocompromised patient, diabetic patients. Staph aureus is the most common. And then whenever there is sickle cell disease, salmonella is the common sites include lower end of the femur, upper end of the tibia, around the knee joint. So bone necrosis there penetrates and forms pus. They lead to sequestration formation, and the shell is called involucrum. There is a history of infection, trauma, severe aggravated by the movement, swelling and redness at the joint, loss of function is there, and it may lead to increased white plate count, white cell count, CRP is increased, joint aspiration gives gram film, culture positive. So treatment is antibiotic has to be there, sequestration needs to be removed, chronic osteomyelitis may be common following surgery and open fractures and tuberculosis. Avascular necrosis is the death of the bone corresponding to interruption of the blood supply. Main joints affects are hip. Many main joints which are affected are hip, scaphoid, lunate, and talus. So vascular growth into the affected causes is plastic racks. P is pancreatitis, L is lupus, alcohol, steroid, S is steroid, T is trauma, I is idiopathic infection. So plastic racks, P is pancreatitis, L is lupus, A is alcohol, S is steroids, T is again trauma, I is idiopathic infection, C is Cassion's disease. Rax is it is radiation, A is amyloid, G is Gaucher's disease, S is sickle cell disease. So plastic racks. So you have to just memorize. MRI shows earlier. So this is about avascular necrosis. All of the things may cause avascular necrosis, fractures at the high risk sites, anticipation, joint replacement necessary. Septic arthritis, most common organ is Staph aureus, and sexually active person, Neisseria gonorrhea. Synovial food obtained for the starting treatment, intravenous antibiotic, gram-positive coca are indicated, flucloxacin and clindamycin. Antibiotic treatment for 6 to 12 weeks, needle aspiration should be used to decompress the joints. That is septic arthritis. Now coming to shoulder disorders, this is an impingement syndrome, mechanical impingement rotator cuff, cause inflammation, insertion of supraspinatus, relatively avascular, susceptible to trauma, and pain may be felt at the mid-arc, that is at the level of 90 degree. Forward flexion 90 degree and internal rotation. Rotation impacts supraspinatus between acromion and greater tuberosity. Also cuff inflammation is there, modification NSAIDs. So what is the frozen shoulder? Now thought to be due to fibrosis of the capsule of the shoulder joint. No predisposing cause, there is no adhesions, there is stiffness and predominant loss of external rotation. So trauma, repeated trauma is there. Spontaneous resolution may occur within 2 hours. Manipulation under anesthesia has to be done. Rotator cuff tears, more common. Supraspinatus tear is most common. Can involve some trivial injury, normal everyday activity, sudden pain in the shoulder, and inability to initiate the abduction. So this is initiation of abduction. Diagnosis may be confirmed ultrasound and CT scanning. So rupture of the long head of bicep, usually previously this is the bunching of the muscles. Tennis elbow is the lateral epicondylitis, and golfer's elbow is the medial epicondylitis. The student's elbow is the olecranon bursitis. There can be because of olecranon bursa. Tenosynovitis, is the inflammation of the tendon sheaths, repeated traumas. This may cause radial stellate dequerring tenosynovitis. So ganglion is a swelling, cystic swelling. This on the crystal clear fluid is there. Aspiration can be done. Insertion, injection. Trigal figure is flexure. Fibrous fracture sheet thickens. Narrower causes friction. Again, the condition occurs at the level of metacarpal head, neck, and nodule passes to the and click snap is felt and triggers sometimes and frankly. So spontaneous resolution may occur 20% requires steroid injections. Dupuytren contraction, palmar fascia is there, etiology unknown, family history of diabetes, alcoholism, liver disease, antibiotic drugs may cause contraction proximal interphalangeal joint and metacarpophalangeal joint, causing affecting little in the ring finger, medial side of the fingers. Carpal tunnel syndrome associated with the pregnancy, rheumatoid arthritis, myxedema, osteoarthritis. Dislocation of the lunate, AV fistula at the wrist for dialysis. Pain and paresthesia of the thumb, index and the middle finger. You can see this is the nerve. You press here, you get tingling on this area. Thumb, index, middle finger. And this is phalange maneuver. Inverted, you just hyperflexion for some time you get tingling on the part. Worse in the bed at night, clumsiness carrying over the movement, wasting of the thinner muscles. Nerve conduction study may help. Mild cases may be treated by splintage. In mild cases, splintage, injection of carpal tunnel with the steroids or decompression has to be done. Now these are the meniscal tears. Here you get it is among the commonly symptoms young males twisting of the knee. So bucket handle tear is common. 40 years pain on the knee, on the meniscus. There will be lock knee. 24 hours immediate swelling. After 24 hours indicates immediate swelling is anterior cruciate ligament, and after 24 hours it is MRCS test is positive in meniscal tear. Plain radiography, MRI to give soft tissue, understand the soft tissue injuries. So ligament is damaged. You can see these are the ligaments. Medial collateral ligaments. This is the anterior surface. This is posterior surface. This is anterior cruciate. This one is anterior cruciate. This one is posterior cruciate ligament and transverse ligaments. So many ligaments. Collateral. There is the medial collateral abduction strain on the tibial medial ligament. Valgus straining. Outer valgus is outward. This is lateral. This is medial. Outer movement is there. If there is hit from the lateral side, this goes to unders, and joint tenderness. Joint will open fully. And lateral collateral injury, it occurs when there is varus opposite. Means rare, and bicep femoris tendon help to stabilize. So lateral collateral is rare because biceps help. So anterior cruciate ligament, you can get hyperextension, usually caused by hyperextension or forward movement of the tibia on the femur. So anterior hyperextension causes anterior cruciate ligament. Examination reveals effusion positive anterior drawer test. Latchman test when the knee is flexed for 20 degree and tibia drawn forward is more sensitive than anterior drawer. So you can see anterior cruciate ligament or drawer tibia anteriorly, anterior drawer test. This is the posterior cruciate ligament. Posterior usually torn by forcing tibia backwards on the femur. Always ligamentous injury. Other ligamentous injury, examination reveals posterior sag. Tibia moves backward on the posterior drawer. Isolated collateral ligaments are in base, multiple coronary injuries. Ankle disorders. Now, what is the ankle space? There is ankle sprain. So, anterior talofemoral ligament is most common. Anterior talofemoral. This may be torn during inversion. So, inversion is there. So, anterior talofemoral is most common. ATF, most common. So, you get a sprain, pain, swelling, tenderness below the front of the lateral malleolus. Rupture of Achilles tendon, you do Siemens squeeze test, something give up and feel kicked back on the hill. Conservative treatment, progressive immobilization, surgical appeal necessary in young, active, and followed by immobilization. So plantar operative repair is done more than. Plantar fasciitis is middle-aged. Pain is under the heel. Younger patient may be with Ritter's disease. Examination reveals tenderness attachment to the plantar fascia under the calcaneum. Lateral treatment is by soft heel pad and all this. Pediatric orthopedic transient synovitis. This is 3 to 8 years. There is history of upper respiratory infection. There is fever few days. There is viral fever. Development dysplasia, mild dysplasia, congenital abnormality, positive, extended breech babies, length equally, slight external rotation is possible. Disease progresses, tendon test is positive. DDH. This is Borlow's and Ortho test. Manual perform adducting the hip, directing force posteriorly. Ortho test is manual, confirm the positive test. Hip is dislocated. It is performed gently, abducting the infant's leg using examiner's thumb. Abduction. This is abduction test, and this is adduction test. You see Barlow cluck of the exit, and this is Ortolini cluck of the entry. Ortolini is abducting the leg. You are abducting the leg, lateral movement. This is adducting the leg. Chunk, exit of the femur from the dislocation. There is exit, and here you are seeing dislocated femur is again putting inside. Ortho means inside, and Barlow, bahar, it is you are moving it out. So adduction is done, and that is removed out. Treatment, splints, harness or traction, later osteotomy and hip realignment procedures. However, the best, if possible, almost require revision. 0 to 6 pelvis harness 0 to 6 months, younger age group. Surgery is needed. 6 to 118, a close reduction in adductor tenotomy. 18 to 3 years open reduction femoral valgus. 3 to 8 years femoral varus. So these are different lines of what is this called as Helgen's horizontal line. Perkins is the D vertical line. This you can see horizontal and vertical line. Shenton's line is the curved line which is broken. This is Shenton's line, curved line. 15-month of DDI showing classical index, increased acetabular index, broken Shenton lines. So Shenton's line is broken and false acetabulum. So what is Shenton's line? It is broken in the hip dislocation. This is Shenton's line. You can see this is Shenton's line, which is broken here. This is the dislocation. Perthes disease is avascular necrosis of the femoral epiphysis, impaired blood supply, femoral head causing infarction, new vessels develop, ossification occurs, bone heals. Clinical features: males more common, and then females bilateral 20%, more than 2 weeks, limping of the hip pain, decreased abduction internal rotation, avascular necrosis. Earlier, avascular change found on technetium 99 scan. X-rays, flattened femoral head, subchondral crescent, calcification. Initially there is sclerosis, then so there is staging. Initial period of ischemia, loss of blood supply, then fragmentation, reabsorption, femoral head collapse, then reossification, then femoral head reshapes. So initially you get a darkening, that is why then it collapses. So slowly, most resolve with the conservative management. Slip upper, there is the obese patient, person is obese, age is about 12 to 13 years, also with increased growth hormones, decreased sex hormones, mild shortening of the limb, increased adduction, external rotation. The disc is slipped here. So bed rest, cannulated talus equina foot. Now equina foot is adduction and varus of the midfoot, high arch. So here you get calcaneus, equinus, and all the tendons, ankle joint. Now you see tibio-navicular ligament, tendons of extensor digitum longus, tibialis, all note the lightness. So management is by conservative. Ponseti method described the gives comparable result. Ponseti method, comparable result surgery. It consists of serial casting mold and foot in correct position following casting. This is followed by a phase of walking. Surgical correction reserved for the cases which fail to respond to conservative management. So, Ponseti method. Now, what is this? Osgood-Schindler's disease, runner's knee. So, what is there? This is a kneecap. There is a tendon. Osgood-Schindler disease happens when the tendon pulls on the growth plate and shin bone. So, this is growth plate and the shin bone. So, autosomal recessive condition involves traction apophysis of the tibial tubercle due to repeated microtrauma. Tibial apophysis 10 to 15 years of age group. Specific point of tenderness, tibial tuberosity tender. Tibial tuberosity is tender on palpation. Pain in the knee after activity. X-ray shows fragmentation. Management is rest. Non-accidental delayed position, delayed attain milestones, multiple injuries, children at higher risk.